Hello everybody, good evening and welcome to tonight's webinar with MSF Australia. My name is Margaret Bell, I'm a midwife and I have done 5 field placements with MSF and I'm now currently the manager of the medical unit here in Sydney and one of the women's health advisors. Now I'm joined tonight by 2 very special guests who will be giving us their perspective on the theme for this evening's webinar, which is Paediatrics and Neonatology. So I'd like you to welcome them. Sitting next to me is Nicola Morton. Nicola is a paediatrician. Nicola's done 3 field placements. That's been Pakistan, Afghanistan and Kenya. And she's about to go in about 2 weeks, I think, to Yemen for her 4th field placement. So welcome, Nicola.
Thanks, Mark. Good to be here.
Nice to have you. And sitting next to Nicola is Kelly Drew. Kelly is a registered nurse and a midwife. Kelly's done 2 field placements with MSF in South Sudan and Afghanistan as well. And Kelly has a background in emergency care and critical care. So welcome, Kelly.
Thanks, Mark.
And you only got back, 2 weeks ago, I think? Last week?
Thursday last week.
So it's really good to have you here tonight. Thank you. So everybody, tonight our webinar will go for around 30 minutes and this is not focused so much on active recruitment. It's focused more on giving you the information about what MSF does in the field, some of the challenges and the realities we face when we're caring for paediatrics and neonates in the field. So we want to share that information with you. It'll be quite medically focused, therefore, so I hope we can keep you all glued to the computer. If you do want information about recruitment, you can certainly go to our website and there are very detailed information there about that. Now, I've noticed there are some questions posted online already, which is fantastic, so please keep those coming throughout the discussion. We will attempt to answer those questions at the end. If we don't, however, our team will get back to you over the next few days to answer your questions. So we might get started. So I might start with you, Nicola, actually. Now, as a paediatrician in the field, can you please describe to us some of the more common problems that you see with children in the context where MSF works?
The most common conditions we see are acute infectious conditions such as complicated malaria, watery diarrhoea, pneumonia, as well as vaccine preventable conditions such as malaria, tetanus, measles. But the other thing that complicates work in the field is that these are vulnerable children that don't have great access to healthcare, so they're often complicated by things such as malnutrition, which means these children get a lot sicker than we would see here with a simple pneumonia.
And I mean, just from my own field experience and talking to our paediatricians here in Sydney, is that often the children don't just come in with one problem, they come in with, multiple problems. Is that in your experience?
Definitely, and it can be multiple infectious conditions, so gastro plus pneumonia plus malaria, or it can be that they have chronic medical conditions that due to the poor access to healthcare just haven't been managed either appropriately or at all. One case springs to mind of a little boy that I treated in Pakistan who was 3 years old, and he came in I think initially with gastro but also had severe malnutrition, and subsequently we also diagnosed him with tuberculosis, and he was very sick when he came in and took some time to get better, and many times during the course of his illness his mother would say to us, he's so sick, he's not getting better, maybe I should just take him home to die. And we said no, we will persevere, and after almost a month in hospital he was discharged home well, and so it can be a long course but usually with a good outcome.
Yeah, and he had access to his TB medications after discharge?
Yeah.
Yeah, that's good, isn't it? It's nice when you have those nice stories. Can you just, if we just focus now to neonates, what, in your experience, I think you've worked in 2 of our neonatal units in Pakistan and Afghanistan, so what are some of the common health problems that newborns face?
So neonatology is similar in the context that we work as well as back here. So the big 3 that we see are sepsis, prematurity, low birth weight and perinatal asphyxia, but obviously mortality is higher and can be quite different to treat, but the top 3 conditions are similar to what we see here.
And with the asphyxia, I mean, I know that there is quite a high rate of that, and so what is a contributing factor, or why is it such a big problem?
So we see a lot more asphyxia as well as a lot more severe in the context that we work for I guess 3 big reasons. Firstly, maternal care. So a lot of the women are in poor health don't have great access to healthcare, and in particular antenatal care. So the pregnancy complications aren't picked up early and can lead to significant consequences for the baby, as well as intrapartum factors. So whether it be because of they're living in a context that there's conflict, so it might be that they hesitate to come to the hospital, or it may be a long journey. Often they present to the hospital quite late in labour with the development of complications, but also postnatal care. So the importance of access to good neonatal resuscitation, whether it's because they've given birth at home or the staff haven't been trained in simple resuscitation.
And it's interesting you say that, because I know, like, if you look at the global stats, they say that 45% of children under 5 die within the first 24 hours. And the implementation of good resuscitation has a significant effect on morbidity and mortality. So yeah, and I know it's something when I was in the field that we rolled out that program, Helping Babies Breathe. I don't know if you've had experience with that. That is now, endorsed by WHO. And it just makes such a difference if you can, get or, assist that neonate in that first minute of life. It has a really big impact. Kelly, I might just ask you now, you've worked in the neonatal unit in Afghanistan, in the hospital in Kabul. So how, with the conditions that Nicola has mentioned, how do we manage those in a context like Afghanistan?
Well, because of the context, we're quite limited in the care and the treatment that we give. So some of the basic treatment is managing seizures, apneas, giving oxygen if required, antibiotics, concentrating on feeding or IV fluids for the baby. We don't have advanced medical equipment that we have back home here in Australia and other countries. So the care that we do is basic, but it's surprisingly effective as well.
And you also worked in South Sudan, which is a very low resource context. Can you maybe just describe the difference in the newborn unit, say, in South Sudan compared to the one in Afghanistan? Was there a difference, and if so, what that was?
Sure. So predominantly there was the training of the staff, I found, which correlates to the standard of care that you give as well. So in Afghanistan, the staff were formally trained. So the nurses and the doctors were formally trained, whereas in South Sudan, they weren't. In fact, we didn't have any doctors in South Sudan apart from the expatriate or international doctors that came in. So when you look at their training in South Sudan, you're really starting at the basics, whereas in Afghanistan, they have an underlying knowledge of physiology that you can build on. So it makes training a little bit easier, and the care they provide more advanced as well.
And then I suppose just the longevity of those programs and having, the right amount of staff. If you can access, the national staff, if you have skilled paediatricians, if you have the skilled nurses and doctors, then, they can be working in your unit, and therefore that sustains that level of care in that unit.
Exactly.
Yeah.
Exactly.
I know that KMC, I think, is that something that we do implement in the field?
Yes.
I think in a wheel they've started that program.
In a wheel they have, and also in Afghanistan as well. In fact, it's really important because we don't have that medical equipment that I mentioned earlier. We don't have incubators, and so the only way really you can get the babies to thermoregulate is against the mother's chest, so skin to skin or kangaroo mother care, which is really important for the preterm babies especially. And it promotes bonding and feeding as well. And research has shown that babies that engage in the kangaroo mother care have fewer apneic episodes, fewer episodes of sepsis as well. So it's a very important.
And is that hard to implement? Because I just know from my field experience that the mothers often have a lot of the children. There's a lot of priorities, just for their basic survival.
Exactly.
So do you find it challenging to implement like true kangaroo mother care when they've got to, in theory, be there for a long period of time with their baby?
Absolutely. Most mothers have children at home that they're looking after. They usually have several children, and they can't afford to be at the hospital all day, devoting all that time to skin to skin with their babies. They have other children to look after. Quite often the mothers have to work themselves if they've lost their husband or have no other carer. So it's very challenging for a lot of the mothers to stay to do the kangaroo mother care.
Yeah. But I guess even, the small time they can is still obviously beneficial for the baby.
Absolutely, and it's a skill they can take home with them too once they learn it. If they are able to stay at home with the other kids, once the child's well enough, baby's well enough, they can do it at home as well. Yeah,
which actually brings to mind the story you were telling us before we started. Nicola's got a really nice story about kangaroo mother care. Can you share that?
Yeah, so while I was in Afghanistan, we did implement kangaroo mother care in our unit, and it was at a time that we did have quite a lot of premature deliveries, as well as that we had a bit of a run of premature twins. I think we had 6 sets in a matter of weeks, and there was one set of twins that I had the privilege to go home to their home to visit them post-discharge and see how they were doing. And these twins had done very well in hospital, with a mother very committed to doing lots of skin-to-skin. And when I went with the team to visit them in their home, she'd continued to do skin-to-skin post-discharge as well, and they were doing really well and gaining weight, which was great.
Yeah, that's nice. It's a really nice story. It's funny you mentioned about the twins though, because I don't know, Kelly, as a midwife, how you found, but there's a lot of twins born in the context where MSF works. And Nicola, I don't know if you've seen that as well.
Absolutely.
And you often, you'll deliver one twin and the next minute, because often, the women don't have antenatal care, so they're coming to you in labour and you deliver one baby, next minute you get a tap on the shoulder and, there's another one coming.
Happened to me in South Sudan. I delivered one and I went to check the fundus afterwards and realised there was another baby there.
Another baby. Yeah. So that's good. So I think talking about the low resource settings, that's something that obviously is a lot of contexts where MSF works, that is the case. And, that obviously in that case there mustn't be clinical or diagnostic equipment or tools available. Nicola, I don't know if you can maybe just talk to that a bit, like, is that what you found? And then how do you manage that as a clinician when you don't have those things available to you?
In the context where we work, we don't have the access to all the tests, both lab-based investigations and radiology, that you would have in Australia. And it can vary from project to project. In one project I worked, we just had hemoglobins and bilirubins, and that was all we could do. But some contexts you have more available. But you definitely become a better clinician. You realise that actually you don't need that chest x-ray to diagnose the pneumonia. Your stethoscope and your clinical assessment is much more valuable, and you do become a better clinician for it. And the basic care is the best care, and often the biggest difference you can make in clinical care. And I think back to my most recent mission in Kenya, where as MSF we intervened in an acute respiratory infection outbreak amongst children in a community, and in particular there was a really high mortality rate in the young children, in the under ones, and we came in and quickly saw that the biggest gap in the care was basic care, and through improving things such as oxygen delivery, monitoring of the children, appropriate fluids, treating their malnutrition, we were able to reduce the mortality from over 25% when we arrived to 0% within a matter of a month. So basic care is essential and can make the biggest difference to these children.
Yeah. I guess we often, we get so focused on our equipment and stuff here, don't we, that we sometimes forget that, I think. But even so, I know as a midwife when I first went to the field that you do see things that you don't see in Australia, of course, and that must certainly be the case with children, with neonates. And at times, I found that you think, God, if only I was home, I would be able to do something for this woman or save this baby. I mean, how do you, I don't know if one of you wants to mention, how do you cope with that in the field? Like, do you have examples of when you have been in that situation where you've just been faced with something that you can't treat, or a child you can't help? Has anybody got an experience? Nicola, I think too.
Yeah, I think definitely there are conditions that you'll see in the field that you won't have seen back home. For example, when I was in Pakistan, we had a measles outbreak, and I'd never seen a case of measles before. And also we had children dying, combined measles with malnutrition, and it's a very bad combination that that wouldn't happen back home. The other thing that I saw that was very difficult was neonatal tetanus. And that's just something that we don't see here at all, because we have good immunisations and good hygiene around delivery, and it is one of the most awful things I've seen to see a little baby suffering from these painful muscle spasms, and a mother who can't hold or comfort her baby for fear of triggering these spasms is very difficult to deal with. But you do have to, I guess, have that perspective that you do what you can in the conditions that we're in, and make the best difference that you can.
Yeah, I saw some tetanus when I was in the field, and it is really, really hard to do that. And I guess that's the thing, is that we do good care, and we and the best care, but sometimes there just are things that you just can't. I don't know if you want to add anything to that, Kelly.
Yeah,
in
it's
your
just
experience.
it is difficult. It's one of the things that I think in your first mission, it's hard to get used to, seeing babies dying of things that would survive normally. I remember when I was in South Sudan and working on Christmas Day, and I went down to the therapeutic feeding centre. They were having trouble cannulating a baby that was dying of malnutrition, and it was so tiny and making these bird-like noises. It couldn't even cry. It was so. I was thinking, at home, all the food people would be eating on Christmas, and you're watching literally a baby dying of malnutrition.
Yeah.
It's
It's hard, isn't it? So how do you manage that when you come home, or how do you manage it in the field? Team meetings, I know we had a lot of team meetings, and you're talking to other staff and stuff. Any other tips from you guys?
So MSF has some good resources when you come home. There's support there if you need it, and there's also the association. You can always talk to other people who have been in the field, which is invaluable, I think. And most people have their own support network as well. It's important to keep talking to your own friends and family. But I find MSF quite supportive when you come back from mission, if you are having trouble.
I used to keep a diary. I think that sometimes helped. I don't know if anybody of you guys used to do the old-fashioned writing, But just getting on to support, I'd just like to mention now, I think, the support in the field, and one of the ways we do support our staff, because you will see conditions like tetanus that you haven't seen before. We have guidelines, and we have guidelines in all areas of health and medicine. And one of the most recent guidelines that we've just implemented is the neonatal guideline, and this was implemented in April of this year. It was written by our paediatric advisors here in Sydney. Because, we all know, and these guidelines are based on best evidence, but also context specific, because we know very well, and we've talked about that already tonight, that what you would do here in Australia, for example, you cannot or is not appropriate to do, say, in somewhere like South Sudan. Now, Nicola, I know that you worked with these guidelines recently in Afghanistan. Can you just maybe share your thoughts on the benefit of them? Did you find them useful, and how do you think that's helped, the work in the field?
Absolutely. I think the guidelines are really beneficial. Firstly, just as a great tool for the expats in the field, to make sure that everyone is following the same guidelines. We have international staff from all over the world with different backgrounds in their training and different, their treatment ideas, and so it's really good to have one set of guidelines to provide consistency for the national staff who are there long term, but also it is best practice for the field, whereas most of us have done our training in big metropolitan centres where the treatment we use back here might not be appropriate, whether that's a seizure medication that's going to cause respiratory depression when you don't have a ventilator. You might avoid that and choose a different alternative, or antibiotics choices depending on the context. It's really important to have guidelines for the field to provide that assistance.
And a lot of the contexts we work with, sometimes we can't get the medications into that country, or they're not available in country and we can't get them in, so it's very important. So speaking of resources, I know one of the other things we've already mentioned a little bit is about training staff, that as doctors, nurses, midwives in the field, part of our job is to provide some one-on-one training. Kelly, can you just maybe give us some examples of some of the training that you've done in the field with staff?
Sure. So most recently in Afghanistan, some of the training I did was just quite basic, but hand hygiene. And even though it's basic, it's incredibly important for preventing neonatal sepsis and infections. And we were able to get our hand hygiene statistics up to 80% compliance, which I was quite happy with. And we're also introducing cup and spoon feeding for the babies having trouble breastfeeding. Previously that was syringing, express breast milk or formula, but the cup and spoon feeding is much safer. The double checking medications, I was also training the nursing staff in. Previously they were just not checking the medications, just giving them by themselves. So it's important the nursing staff check with someone else to make sure the right baby's getting the right medication and the right dose. And also really encouraging the skin-to-skin contact as well. So not just in the newborn unit and in the Kangaroo mother care unit, but also right back at the start in maternity, making sure the babies are having skin-to-skin contact. We're having quite a few admissions of babies not long after birth with hypoglycemia and hypothermia. And so trying to prevent that, we went right back to the start and getting the midwives to do skin-to-skin from the start and implementing early breastfeeding. So basic training, but very important for the outcome as well for the babies.
And I mean, I know breastfeeding is something that we do, obviously focus on in the field. Can I just ask, have you found in any context where either of you worked that there's a reluctance to breastfeed or to, how is that in Afghanistan?
No, the mothers in Afghanistan were quite willing to breastfeed.
Yeah.
It's not always appropriate for the babies in the newborn unit, especially if they have asphyxia. It's not always appropriate for feeding to start immediately, but certainly if it's appropriate, I've found the mothers keen to breastfeed in both South Sudan and in Afghanistan.
And they obviously have, we can do nasogastric feeding if necessary.
If necessary, exactly.
Yeah. So just in regards to training, for your information, we do also have formal training programs, and we have this year we implemented a 2-week paediatric training in our headquarters in Paris. We also took that training to the field in Mali, and I believe it's going to Yemen, I think, in a few months' time. We also have training in SRH and sexual violence and other disciplines as well, so that's something else that MSF does provide. Now, I think we might just go to some questions. So we've got a question here, maybe Nicola you could ask this. So there must be many resource poor settings in which equipment we use in developed countries isn't available, and yes, we have alluded to that, but equipment such as CPAP. Nicola, have you in your field missions ever used CPAP?
No, the context I've been in, we don't have CPAP or definitely not ventilators, but there are some contexts where MSF is working that do, and it will often depend on particularly staff capabilities and how sustainable that is with national staff. So, for example, in Jordan, they're able to provide CPAP in their neonatal unit, and hopefully soon in other contexts depending on the situation, but often it's not able to be implemented for those reasons in certain contexts.
Okay, that's good. And we have another question. So this is about breastfeeding. We may have already answered that, but are there neonatal units MSF work, where MSF works, that are BFHI accredited or have a focus on breastfeeding kangaroo care? So I think we've answered the kangaroo care, because I know you talked about it in Afghanistan. I know it's in a wheel, and I do know that we are in all our other newborn units. Nicola, I don't know if you found that as well, that Pakistan, we are implementing kangaroo mother care. Yep.
Yeah.
And strong focus on breastfeeding. From my experience with the BFHI accredited hospitals, I don't believe that many of them are accredited, not because they don't want to be, but I think that is just not available. That accreditation process is not available in some of the contexts we work, the high conflict areas or immediately after natural disaster. Any of you want to comment on that, if you have any more experience than myself?
No, I know in Afghanistan there was an accreditation process in place, but it wasn't very advanced. But I think there was some assessment of hospitals there. But like you said, in the majority of contexts, it's simply not available. Even though we're adhering to the same standards, the accreditation process just isn't available.
Yeah. I'm glad you haven't experienced that.
Yeah, I mean, the context I've worked in, there hasn't been the accreditation process, but there's definitely a big focus in all MSF neonatal programs that I've worked in to really promote breastfeeding and early breastfeeding. And definitely in some contexts it's more difficult. For example, in Pakistan there was a resistance to breastfeeding, and we were seeing a lot of malnutrition in under 6 months because of that. But definitely it's a big focus in our neonatal care.
And that resistance, why was that?
It's hard to know. Part of it was the belief that if you could afford formula, that was a better option, and we would have people coming to our feeding centres being quite resistant to us trying to re-establish breastfeeding, requesting formula. A lot of it was women having to go work on the field, so they couldn't be there to breastfeed their baby, and it was other female caretakers feeding the children. So, yeah, it was quite a difficult context.
It's interesting, that thing about it, isn't it, that if you... I found I did a field visit in Pakistan just for a short period to support the team in the field, and it was about, the more equipment you have, the more tests you have, the better your care. So I guess it's a little bit the same, that, artificially feeding can show your status in society. It's interesting, isn't it? Yeah. Now we have another question here. If I was selected to go to the field, what would I be undertaking? Would I be doing direct clinical care, supervision of others, and/or education-based training? Well, certainly, I think it depends on the context. I don't know if you both agree, but some context, if there is no national staff to provide that direct clinical care, then as doctors, nurses, midwives, we would be providing that. Certainly, you will be supervising other staff to some, for some level. So it could be supervising other doctors, nurses, or it could be supervising staff that you are training, like in South Sudan, that aren't formally trained, but you are supervising them to carry out that care. And/or education-based training. So yeah, I think what we've mentioned earlier is just that there's a lot of, you are expected to do one-on-one training when you're in the field, and that is a strong focus. And then of course more formal trainings will be conducted by headquarter staff coming to the field in collaboration with yourself as well. Now we have a question here. In the areas where you are providing newborn care, which are clearly third world countries, what is the gestational cutoff in terms of viability? It's a very good question. Do you want to start, Nicola, answering that one?
It is a good question, but a very difficult question. And often, we don't, like here, we don't have a set viability, but it often is based on what equipment you have. So in a neonatal unit where you have access to CPAP will be different versus a unit that may have incubators, may not have incubators. So it is variable. I've worked in contexts where the cutoff is 1 kilo. I've worked in where there's 1.5 kilo, and it is more weight-based because we are talking about contexts where women don't have good antenatal care. The dating's often unreliable, and so we never use a 100% cutoff, and if you're 1 gram over that, no. It is a very difficult question, but
and I think it's about what is, I think you mentioned it earlier, Kelly, it's about what is then sustainable for life outside of the hospital. And often the context we work in, what's the food like outside of the hospital, that the general living conditions outside of the hospital. Also, is electricity available? Can we run ventilators? Can we run CPAP? So, unfortunately, it's not a cut and dry answer. It is really context specific. But I do know just from debriefing and briefing staff, it is one of the challenges that people find, and probably you found it yourself, that can be a little bit difficult to. I'll use the word get used to it, but to manage that in the field, I think, isn't it, when we are used to saving really tiny, tiny babies here.
Absolutely.
Another question at the top, what are the qualifications necessary to work in the field of neonatology? That's a really good question, because I actually was going to ask you, Kelly, about that. So we'll get to answer that in full, but I just want to go to you first. So you're a midwife, and you don't have any formal training in neonatology or neonatal nursing per se. Sure. So what skills do you have as a midwife that have been transferable to working in our newborn units in the field?
Sure. So as part of my midwifery training, we're trained to look after newborns, and part of that training involves a rotation through the special care nursery. So we have that basic training. I'm also a flight nurse, so we're trained to transport neonates, and we work with the Neonatal Emergency Transport Service as well, the NETS crew, when they do a retrieval. But most importantly, we're not teaching advanced skills in the field. You're not teaching the staff to look after ventilated babies. We don't have ventilators, so they're very basic skills that you're teaching, the equivalent probably of a special care nursery. So like I mentioned before, they're basic skills, not advanced. So please don't be disheartened if you don't have postgraduate qualifications. You can still certainly apply and come and work.
So I think it's basically, having that clinical experience, whether you're a midwife, whether you're a nurse or a doctor even, just having some clinical experience in neonatal care. So please apply, and then of course the recruiters will discuss that with you as to whether you have the appropriate skills or not. Well, I think we're just about out of time, so I'd just like to take this opportunity to thank Kelly and thank Nicola very much for coming in tonight. It's been really good having your perspective on it, and particularly your recent perspectives, and good luck with your next mission.
Thank you.
And Kelly, have a good rest after just getting back to your field. Thank you all very much tonight as well. Thank you for your questions. Now, I know we didn't answer all of them, but as I mentioned earlier, the team will get to answer those over the next couple of days. So I think we'll just end there. And again, thank you all very much for joining us tonight. And please keep on our website and so you know when our next webinar is. And we will look forward to seeing you then. Thank you very much. Good night.